training. The lacrimal gland, actually the lacrimal gland is the accessory lacrimal gland, which are probably more important. The Bowman glands and goblet cells that all provide the goodies, the mucins, the lipids, and aqueous that constitutes a tear film. And any disruption of that will cause a problem, and you have this wastebasket condition called dry eye. But on top of that, there's also a functional element and a sensory that's mediated through sensory motor pathways, and that's lid blinking and then also lid closure. Lid blinking has been underrated, but if you watch patients when they come into your clinic, you watch whether they blink or not. It's amazing how little they do blink, and so no surprise they've got dry eye. Lid closure is very important. If you can't close your eyelids, you're going to be dry anyway. You've got lack of ophthalmos, especially when they wake up in the morning, they're going to have a problem. And if they can't close their lids, they can't pick up the meniscus of tears and wipe it across their eye. So they've got so-called dry eye, even though they may have tears down there, but the dry eye is because they can't close. So there are many aspects to dry eye. Now the Dew study, which is fantastic, came up with this big table and they divided dry eye into aqueous deficient and evaporative. And that's the sort of terminology people are using now, and I think it's great that we're all becoming consistent in our terminology for dry eye. You know about aqueous deficiencies, it's Sjogren's syndrome and non-Sjogren's dry eye. And they can be from a variety of causes between the autoimmune side, lacrimal gland obstruction, lacrimal deficiency, reflex block from, say, laser eye surgery where you've got temporary neurotrophia, and also a lot of drugs can cause dry eye, both topical and also systemic, even antidepressants, for instance, cause dry eye. And then there's evaporative, which is really by far the biggest category, evaporative dry eye. And that, the big brother, the most common cause is vitamin oil deficiency, which is why we concentrate a little bit on omegas. But then, as I already mentioned, if you've got a problem with lid aperture, you're going to get dry. If you're not blinking, you're going to get dry. And then there are other extrinsic factors like vitamin A deficiency, preservatives, topical drops, contact lenses, and so on. So I'm going to talk about my approach to dry eye. With that introduction and understanding, encapsulated dry eye, I'm going to talk about my approach. And a lot of it is going to sound very simplistic, but you've got to start somewhere. And sometimes it's good to have the whole picture. So I'll concentrate on the history, the diagnosis, and then the management with emphasis on evaporative dry eye. In the Dew's report, they talked about meibomian gland dysfunction as being a condition that's the most commonest cause of evaporative dry eye. And I would argue the most commonest cause of dry eye overall. Now I've added, they talk about evaporative dry eye and aqueous deficient dry eye, but there's actually another component. A lot of patients have both. They have more of one than the other, but they also have inflammation, and that's something to be considered. Now you don't always see the inflammation. That's obvious. And then if you look at some lids, they've got true blepharitis, inflammation of the lids. They're inflamed. They've got telangiectasia that are staring at you in the face. It's like a big truck. But then there's subtle signs of inflammation. And they're usually symptoms of inflammation that a patient's going to outline to you. So I try to put the whole lot together and weigh each group. So the symptoms that they come in with, and the symptoms will tell you a lot. Grittiness, burning. Burning is interesting. Why do they get burning? Well, fatty acids from poor meibum quality will cause burning. Itching is another story, right? It could be allergy related. It could be anterior blepharitis. The lid stuck to the eye and awakening. Well, that's an interesting one. That could be because they got lack of ophthalmos. It could also be because they got aqueous deficient. So you're already getting a clue as to which direction to go into when they're speaking to you. And they use the same terminology. It's patients in a culture where language is quite similar. They'll use expressions that will guide you. Eye fatigue. Why do they get eye fatigue? Well, if you have a tear breakup time that's only 3 or 4 seconds, that means you've got to blink every 3 or 4 seconds. Normally blink about 4 to 6 times a minute. Well, they're blinking 20 times a minute. Well, if you had to, if in a day you walk 2 kilometers a day, but you instead had to go to 6 kilometers a day, you'd be tired, wouldn't you? Well, the lids do the same thing. At the end of the day, they say they're tired. Well, not surprising. They're blinking like crazy. So we used to be dismissed. I used to dismiss when I speak for myself. When patients say I've got tired eyes, and what's he talking about, tired eyes? And that's a sort of a rubbish symptom, but actually it's not. eye fatigue. And the classic one is excessive tearing. You know, doctor, I go to the wind, and then like, my eyes start tearing. Well, that's classic, isn't it? Classic evaporative dry eye. So very useful to talk to patients. Very important to also know what drugs they're taking, because that could influence it. You just change, you stop some of those drugs and you tip them over into equilibrium again. We use both these questionnaires because they're both pretty good. The speed questionnaire, which we got from the tear science group, and the ocular surface disease index one, and they correlate fairly well, but they come from different angles. It's great for subjective scoring. It also is fantastic for patients because the ones that we come to us have been everywhere. And for the first time, we're actually taking them seriously. We get them to fill out questionnaires. We're curious to know about their dry eye. And yeah, that's already a good start in terms of relationship with the patient. So I would encourage you to use it. And it's great because you can turn around to patients because the improvement is so slow. The only way you're going to reflect it is from the questionnaires. And you can say, well, you know, your OSDI score was 23 last time you came, your speed score was 23 when you came in last time, and now it's 16. So you may feel you got a problem, but actually you have improved. So it's good for interval change, and it also serves as a guide. Some of the content of the questionnaires will guide you, even if they haven't spoken to you and verbalized their problem. The scores of, you know, they got more burning, then you know which direction to go into versus itch. And then once you've done all that, then this comes to the clinical evaluation. What's going on with this patient? Well, what I usually do is I just look at the patient and I'm watching them while they're talking to me. You know, are they blinking? Are they not blinking? Because I don't want to prompt them. If they're not blinking, I already know that there's an issue. If they're blinking like crazy, that's another issue. And and then I go to the slit lamp evaluation where I look at the lid closure. It's one of the first things I look at, you know, get them to close their eyelids. And if I can see lack of ophthalmos there, you know, I'm already on my way to sorting them out. So, yeah, look at the blink rate, and then the puncti. It's amazing how people forget these things. And then I, you know, once I've got that out there, and then I look at the lid margins in more detail. And, you know, blepharitis is another wastebasket diagnosis, right? You know, everything goes into blepharitis. But actually, there are different causes of blepharitis, and there's anterior blepharitis, and there's posterior blepharitis. So, speaking about anterior blepharitis, you look for collarettes, right? And there are different types of collarettes that tell you different things about what's going on. Also, they also guide treatment. So, basal collarettes, the ones that are golden, they're not too common, but if you do see them, and you pick at them, they have an ulcerated lid margin. Well, you know that's staphylococcal disease. If it's scurf, a bit like dandruff, well, that's seborrheic. And if they have sleeves, you don't need to pull out the eyelash to find out if there's Demodex there. You know, that's the excrement from Demodex, and that guides you in terms of what they should be treated. Why should they be having these things in the first place? Why do they have anterior blepharitis? What's going on? What's tipped the balance to allow these sorts of problems to take place? Whether it be a fungus, if it's seborrheic, quite often is, or Demodex. We'll come onto that in a moment. Yeah, and then you look at the meibomian gland orifices. You know, they inspissated, they're bunged up, and and if they are, you squeeze on them. Can you elaborate anything from them? And when you do squeeze on them, are you getting, you know, what's the quality of the meibum? Is it thick toothpaste, or is it turbid, or is it clear? And often you'll find ones that are clear. You push up the lids, the orifices suddenly open out, and you get this clear stuff coming out. Well, you know, that person's probably got an okay quality of meibum. And then you look at the level of inflammation. And the inflammation can be the lid margins, but also the palpebral conjunctiva and the bulbar conjunctiva. And often, looking at the patient from a distance, you get a good idea as to whether they're inflamed or not. And often you get no obvious signs of inflammation, but they do have inflammatory dry eye. And you know, that's why patients who put them on FML or steroids, they get better and they feel better. And they can see patients on steroids for a long, long time. We're not treating the cause, we're treating a symptom. And you know, we should treat them because they're uncomfortable. Prior to squeezing on the glands, though, you do want to do some functional tests, like a tear breakup time. So conjunctiva, you're looking at the bulbar conjunctiva, the palpebral conjunctiva, and then fluorescein staining that comes along, and you really need that to do tear breakup time. What I do is I use a fluorescein strip. I don't use that, you know, the stuff with the minoxidil in it, because it kind of screws up the tear film, and there's a lot of fluorescein in there that goes down their face. So I prefer just to put a drop on a fluorescein strip, pull the lid down, put a little bit on, and I rush to take a look to see what these guys are doing in terms of their blink. do they blink properly? Are they picking up the tears and wiping them across the eye properly? And you'll be surprised. It's only when they do, every so often we blink normally, and then every 4 or 5 blinks we usually have a slightly forceful blink, and that's about the only time sometimes that they actually move the tears. Well, that's not very good. And this is sort of the retraining that they've got to do when you teach them about their blink. But that's very useful. The wiper action, looking at the tear meniscus, is it the familiar 1 millimeter? Does it have that decent meniscus there, or is it completely absent? And then when you're looking at stain, you need to look at the conjunctiva as well, not just the cornea. It's great. You see this over here. This is the person who died of fun. Comes down the cornea and stops. Everything below it's got a keratopathy. But then you've got to look at the conjunctiva too, and that's where some of the special stains like rose bengal and intermediate green are useful. And in patients with aqueous deficiency, dry eye, Sjogren's and non-Sjogren's, you'll get a good idea as to what's going on. And it's also important to quantify this. You get a diagram of the eye and X wherever you see the staining, and that's your baseline. And you know when the patients are getting better when you stain them at a future interval. Some of the specific investigations, tear breakup time and a Sheraz test are like the vital test that you need to do. Very tedious for ophthalmologists to be doing Sheraz tests. We train all our technicians to do it, and they do it on every patient that comes in for refractive surgery, for instance, and every patient that has any sort of dry eye symptom. So our technician will talk to the patient. The moment it sounds dry eye, they don't even have to ask me. They just go ahead and do a Sheraz test. Often I wish they wanted to take a look at some new technicians will stain up they'll wreck up the cornea, and they'll mislead us in terms of corneal staining. So in those sort of situations, you might want to put fluorescein in first, take a look, and then say, oh, off you go and get a Sheraz test done. But Sheraz test without topical anesthesia never made sense to me. It's okay for patients with Stevens-Johnson syndrome or severe aqueous deficiency where you want to see if they, irritating their eyes will produce some tears. But really what you want to know is the baseline tear production, Sheraz with anesthetic. So others, glands of Wolfring and Krauss doing their job now. LipReview is a new test that's available to look at the tear film, and it uses interferometry to look at the thickness of the tear film. We have this, and it's not bad. I'm not sure about its reliability from case to case because the tear film is a dynamic thing. What we're doing is taking a snapshot. The printout does show how the tear film changes, but it can change. That's over the minute that we examine the patient. But what about at other times? So it's just a snapshot. Mammography, I think, is very useful. This is what it looks like. We use an infrared light. It's actually not expensive to do. I'm trying to source it the right infrared LED to do it, because you can use a camera with the right illumination and pick this up. But the companies that do mammography charge a huge amount of money for their kit. And tear osmolality is an interesting one. You see this tear lab things where they take a little bit of a few nano pieces of tears and measure up the osmolality, and if it's high, your patient's got dry eye. Well, they tell you that from the symptoms they've got dry eye. This is mammography that shows where meibomian glands are absent. And some of these things, if they've got completely absent meibomian glands, then that's a real problem. That patient's going to have problems for the rest of their life. We're going to try and avoid dropout and pick up this patient's early. The tear science solution is LipReview that measures the tear film thickness, and the delivery mechanism for LipiFlow, which is to fix meibomian gland disease. And again, we have this device, and Marcella does most of the treatments at Centre of Sight. It's good, but we've realized we need to pre-treat patients before we actually use this device. It's not a panacea. But it is very useful for patients, and they come in wanting it again a year later because they couldn't be bothered with maintaining their scores. So this is what the interferometry looks like. This is good, thick tear film. This is not so good. And there's bits in between all over the So when you've done all this, you've got your history and so on, and then your clinical findings. Then you kind of need to score them. Now, I didn't actually physically score. Well, I think there's got 3 points for meibomian gland disease, 2 for aqueous deficiency. I just have a sort of an impression of what's taking place, and then I'll decide a treatment regimen based on that. So the goal is really to reduce symptoms, and lubricants are the mainstay. But then you need to treat the underlying cause, and you need to treat the inflammation when it's there. So this is very clear. This is an example of an inflamed eye. That was injected. There's a bit of a mess. They got two injectations. This is an inflamed eye. So that patient's uncomfortable. You know why they're uncomfortable. You can put them on steroids and they'll do well, but the moment you stop the steroids, they'll have a problem again. And you can't keep them on steroids forever. So aqueous deficiencies, Sjogren's, non-Sjogren's, deal with the drugs, deal with the lacrimal dysfunction is hard to deal with. Reflex block is hard to deal with. Their mainstay of treatment is increasing lubrication, punctal occlusion, and a lot of understanding, talking to them about their problem and how they're going to have to try and live with it. Evaporative you can do a lot more for. And the main problem here, the most common problem is meibomian gland dysfunction. Yes, if you have lid closure problems, fix it. Take the lid shut or get an arthroplastic surgeon to realign the lids, and that works very well. Put a gold weight if they have an issue there. The blink rate is something that sometimes needs to be addressed, and I tell them that they need to learn to blink a bit more, and, or take a break from reading for every 20 minutes for 20 seconds, and just blink like crazy, then go back to it again. And that usually helps. They don't decompensate and have big problems if they do that. Get rid of some of the drugs, preservatives, and any other drugs they're on. And if they're contact lens wearers, that's a big issue. Vitamin A deficiency doesn't exist in the modern world, not that I've seen anyway. So, what about the lid margins? Well, again, specific. So if you've got seborrheic, you might want to give them, get them to shampoo their hair and their face with Nizoral, antifungal, staphylococcal, fusidic acid, or a specific anti-staph medication. And for Demodex, well, you can use metronidazole on the face, and or you can use tea tree oil. That helps. But as I said earlier on, why do they get these things in the first place? I believe that it's opportunistic. You've got an environment on the lid margins that is not very good, and it's an opportunity for problems to occur, for Demodex to have a field day and have a feast on poor meibum, for instance. For meibomian gland disease, all patients, in my view, should get omega-3 supplements, and PRN is a great one, which I'll tell you about why in a moment. And they all get warm coppers as the scrubs. They hate doing it, but we emphasize it. We've got some great videos from Eye Imaginations that we show them, and it's good because in 30 seconds to a minute they've got a good understanding of what's going on. And it also sounds very authentic because it's not just me saying it. There's a video made about the problem, and it's amazing how patients take to it once they watch it, once they see a video. And if they're inflamed, they use Lodomax. And Lodomax, as you know, has less likelihood of causing cataract and also glaucoma because it gets de-esterified, and any excess is removed very quickly from the eye and the body too. And lipid do I do lipid flow? Do I advise lipid flow on everybody? No. If they're better on this regimen, then that's fine. If the only time we're now doing lipid flow is if they've been pre-treated with omegas for 3 months. Because it's pointless. If you can use lipid flow to squeeze out all the meibomian gland secretions, and they've got poor oils in their body, all they're going to do is fill them up again with rubbish, right? So you want to change that environment first, change the constitution, and then get rid of the rubbish. I've not mentioned tetracyclines. They're also very useful. The ways in which they work are interesting, but I don't believe that they're the fundamental problem. They're addressing the fundamental problem. They do improve symptoms, and visibly so, especially in certain categories of posterior blepharitis. So what are omega-3s? Well, the polyunsaturated fatty acids, and these are the 4 big ones. Now the top 3 are derived from fish oil, and the bottom one, alpha-linoleic acid, comes from vegetable sources, flax seeds, and there's another seed I can't remember the name of, where you got huge quantities of alpha-linoleic acid. I think it's when I was at school in India, we had ragi porridge. What's ragi, Mike? Ragi.
Wow.
It's like a seed. It tastes like sand.
It's a white seed.
apparently it's full of linoleic acid. It's very good for you. But it's not something that's widely available in this part of the world, except maybe in Wembley or someplace, right? Anyway, but it does require conversion within the body to EPA and DHA. So why PRN? What's different about PRN? Well, when fish oils are extracted, they're in a triglyceride form. They're omegas in triglyceride form. And to get rid of the smells and the mercury and toxins, they use alcohol, a microdistillation process with alcohol. And when that happens, they become ethyl esters. Well, the human body did not evolve to have omegas that had ethyl side chains on them. So a lot of the omega that's taken with ethyl esters is not absorbed. Then you get patients complain of fish burps and repeating on them, getting heartburn and so on, and that awful fish smell when they do get the fish burps, and they hate taking it. But it's not getting absorbed. Well, big reason why that happens. So what PRN does is very clever. They re-esterify it back into the triglyceride form, the same form that was derived from the fish in the first place. And that's highly absorbable, certainly more so than the ethyl ester form. And that's the benefit of PRN. So it's a clever product. And this principle is being used for other things as well in the nutraceuticals market. You're trying to make molecules back to their original form because the processing changes them. So what is the therapeutic dose and in what form? Well, there's some interesting work done on the optimal dose for omegas. And what we're looking for is an anti-inflammatory dose. It's, taking a small capsule a day is really not enough. There are a lot of investigations on inflammatory disease, and I'm talking about arthritis in particular. I've looked at dosages of omegas, and they found that that people range in terms of intake from 1 gram to 6 grams a day. And what they found is 2.7 grams is a minimum. Anything above that, and you're now curtailing inflammation. Well, if it's good for inflammation in the joints, it means it's at a therapeutic level. It's probably good for the eye too. So that's the sort of dose that we need to be looking for in terms of ingestion and delivery for our patients. What about the bioavailability? Well, this is a study comparing re-esterified or trans-esterified omegas versus the ethyl ester form. And what they found that the bioavailability was superior. It's 124% versus 73% with the ethyl ester form. So much more bioavailable when re-esterified. So in a nutshell, you need to give patients more than 2.7 grams a day, and really you can tell them to eat more fish, but you can't get that kind of amount of fish oil from eating just only fish even every day. And yes, the re-esterified form is better absorbed. How about lipid flow? A lot of people are curious about lipid flow. I think it's a good device, and they say we have it and we use it. The company would like every person who walks in through the door to have it. It's very expensive. The disposables are quite sophisticated. There's a ceramic cup that keeps the eye cool, but it heats up the lids to 42 degrees, and then it has a very sophisticated pulse-style pumping that goes from the peripheral parts of the lids towards the lid margins and squeezes out these oils. And Masada, once the lipid flow treatment's done, she'll go take a patient into the slit lamp and squeeze them even more to get any residue out. And it does work. Some patients it's fantastic, they think it's the best thing they've ever had, and others it makes no difference at all. And we're going to find out that really, if we pre-treat patients with omegas, and they begin to produce some good mibum, the mibum qualities change, then they actually do quite well with lipid flow. And it's a good treatment, but you get sticker shock when you find out what the price is to buy it, and also the disposables are very, very expensive too. So is lipid flow any better? Well, this is just comparing lipid flow, this baseline, and 1 month and 3 months, but lipid flow alone and lipid flow with manual expression. And manual expression, which is what we advise our patients to do after their lipid flow, is important, and it has the edge. It doesn't make sense to have the lipid flow and not to continue warm compresses and scrubs. It's not I don't believe that it's a substitute, although some patients will treat it as such and will come back every year for another treatment. That's up to them. If they want to spend that kind of money, it's okay. We'll collect. This is a mean corneal staining scores that decrease and decrease over time. So it's not just immediate, it gets better over time. And often patients will complain, actually, initially, they're much worse after lipid flow treatment. And why is that? Because we're getting rid of all the old meibum that's probably broken down to fatty acids and it's got old cytokines that are causing inflammation. Well, you're going to get a huge dose initially, and then improve in time. The speed questionnaire, which is what we use, I mentioned earlier on, their score ratings start going down and continue to go down. I'm not sure why the manual expression scores are higher. It doesn't make sense. And the OSDI, it's another questionnaire. Again, the scores decrease in time. So my own personal observations, omega-3, is interesting. We measure Schirmers in our patients, and I've observed, and we've not studied it, and I think we should, the Schirmers in these patients improves after 3 months. Why would improving lid disease improve the Schirmers? Anybody any ideas? Strange, isn't it? But it's I'm not the only person who's observed it. Greg Smith in the United States has observed the same thing, and Frank Bucci was another investigator for PR and observed the same thing too. And I just got another patient the other day, actually took her a year, and now she's got a Schirmers of 2 and 3, when it was 0 a year ago. So what's happening? I believe that the underlying inflammation caused by membrane gland dysfunction from omega-3 deficiency affects the production of tears. There's some cytokines that seem to stop. It's like a bit like a mini war zone. You can't build anything, you're not secreting anything. They don't produce any baseline tear. The baseline tear production is poor because they've got underlying inflammation. We also notice that the blepharitis gets better, without specific treatment. They don't have the collarettes anymore. They don't have the scurf and everything else. Telangiectasia less pronounced, which tells me that the inflammation is decreased. And the turbid secretions definitely change. They become thinner and clearer as time goes on. So the question is, poor meibum, does it cause inflammation? I believe it does. And what evidence is there out there to support the use of omegas in evaporative dry eye? Well, this is a study from 2005 looking at the relation between omega-3s and omega-6s. And basically found that the higher dietary intake of omega-3s was associated with less dry eye syndrome in women. Also fish consumption. Those that had 5 to 6 servings of fish every single week had a reduction in dry eye symptoms by 66%. A nutritional study. And this is a study done by Greg Smith. And what he did was looked at meibum, the quality of meibum, before and after starting re-esterified omega-3s. And found that 82% of patients at this dose showed a change in the composition after 8 weeks. And they also found that 70% became asymptomatic, and all patients noticed a decrease in the severity of their complaint. And objective findings are those with hyperosmolarity improved. And the meibum analysis showed for the first time that omega-6 levels decreased and omega-3 levels increased. So with the change in quality of meibum, they also found more omega-3s compared to before starting the treatment. This is the most controversial thing that's going on right now. So here I am taking 3 capsules of omega a day, religiously for the last couple of years, and I feel good. I think that, as I was talking to others earlier on, arrogance is an antidepressant. It makes me feel good. I take it. And then this thing hits the newspaper about prostatic cancer. I'm moving to that age group now. I'm 50, and you start worrying about benign prostatic hyperplasia and prostatic cancer and so on. So this group, Brasky and company, came up with this study that hit the headlines and was all over the world and scared all our patients about this issue of prostatic cancer. And there's some real problems with the study. There's actually been dissed by a lot of people out there. I took a look at it myself, and the fundamental flaws are, firstly, they looked at plasma levels. Now, if you look at plasma levels, it's like looking at a plasma at a glucose level for a diabetic. If you don't use a fasting blood glucose level, you're not going to know what their tendency for hyperglycemia is. Also, we use HbA1c for glucose, don't we? To have an idea as to what's going on in that patient. If the HbA1c is high, you know they've got hyperglycemia all the time. Well, the same applies for omegas. Taking a plasma level depends on what they've just ingested and what time and what form of omega. What we really need to do is take red blood cell levels, because that gives you an idea of the medium-term levels of triglycerides and of omega-3s in the body. But you look at the data closely, so these are plasma levels, and even if you look at the plasma levels, the differences in plasma levels between the groups is not very much different. So 4.48 lower levels of omega-3s in the non-cancer group, and 4.66 in the overall cancer group. So they're not hugely different. Somehow they found some statistical significance there somewhere, and I couldn't understand that bit in the paper at all. And we looked at low grade and high grade. Again, there was not a huge amount of difference in the levels. But if you do a PubMed search on prostatic cancer and omega-3s, these are the ones I found right away. 7 studies that showed that actually prostatic cancer decreased with intake of omega-3s. And the really funny one was, if you notice that name Brasky, well, that's Brasky. His group showed previously, same group published a paper 2 years ago showing there was a reduction in prostatic cancer. So where did they go from showing a reduction in prostatic cancer to now showing there's an increase in risk of prostatic cancer? So I think either the jury's out, or this is a little bit more convincing. But as with all these things, you know, if it's a bad news story, possibly it hits the press. There's no press about the fact that omega-3s possibly reduce prostatic cancer. So I think that'll be evaluated further, and there are independent urologists who've taken a look at this and said that this is pretty ridiculous. The study was extremely poor, and you could find an association with anything. You're driving a Cadillac might give you prostatic cancer, for instance. So I think they need to look at it. I personally am not particularly bothered about it. So when my patients ask me about prostatic cancer, I just say to them, look, there are more studies that show it actually reduces risk of prostatic cancer, and the study's flawed because they measure the levels of omega-3s incorrectly. So in conclusion, PRN, omega, I take it, and it's good for ophthalmologists, it's also good for patients who have dry eye, evaporative in particular. Thank you for your attention. Any questions, John? Maybe you want to ask Tom some questions. Yeah, Simon.
If omega-3s are so good, have you looked at, or has anyone looked at the rate of blepharitis or meibomian gland disease in countries where fish is very high in their diet, for example, Japan or...
Yeah, and it's lower. The rate of blepharitis is lower amongst Eskimos and the Japanese. And also when I was looking through the literature about prostatic cancer is also lower in Japan, where there's a high fish intake.
And what is their, has anyone looked at their blood levels? I mean, have you got a feeling of what the blood levels of these people is?
People have looked at it, and looking at plasma is a problem. But to measure red corpuscle omegas, there are not that many centers that can do it. But that's what you need to measure. I think in the US, there are the special centers that do it. And it needs to be more commonplace, and people are going to use that for diagnostic purposes. But for research purposes, yes, they are looking at that more and more now. Especially with this controversy now with prostatic cancer, that's a major deal. You know, the people have looked at the rate of heart disease. You know, omega-3s reduces heart disease, and they've done this. When the study came out, they compared the health economists looked at the impact of reducing the intake of omega-3s because of possible prostatic cancer, you're more likely to die of heart disease if you reduce your intake of omega-3s compared to prostatic cancer if you're a man. So there's a lot of, it's certainly spurred a lot of interest, and I think we'll see more and more work done with omega-3s. But if there's anything close to a panacea generally speaking, I think the omega-3s are it. So why are we seeing more problems now with omega deficiency? I've been doing ophthalmology for 25 years. I see more blepharitis and dry eye problems than ever before. So why now? What's been happening all these years? And you see young kids with it too. Well, a lot of it's to do with the food chain. The way in which the animals are being bred for our dinner plates is, battery farming. Chickens in little cages getting fed corn. Well, they didn't evolve to eat corn. It's a food substitute that's got zero omega-3s, got a high quantity of omega-6s. So the meat looks good. Our cows are eating corn too. And that's not what they evolved to eat. So you got this nice, great big ribeye on your plate, but it's got no omegas in it, or very little compared to what it might have been if it was grass-fed, or in the bygone days before the era of corn-fed animals. So I think that's got a lot to do with it too. And can we substitute? If everybody has to supplement themselves with omegas, there's going to be no fish in the ocean. And I think we need to find ways to use vegetable-derived omega-3s in vast quantities to supplement ourselves. I think it's going to, as we find out more, I think omegas are going to be even bigger news in the future.
What is the rationale of linking omega-3?
Sorry?
What's the rationale of linking omega-3 to prostrate only? Why not intestine or why not stomach?
Well, that's what they looked at.
Just because the guy was interested in prostrate.
Well, the study was looking at prostate cancer. They're looking at prostate cancer. And they're looking at a variety of ones, selenium and something else. They're looking at the impact of selenium and something else in prostate cancer. And they also looked at omegas at the same time. But this is a group that deals with prostatic cancer, which is why that's what they looked at. But yes, I think they could be looking at all sorts of things.
Exactly. So,
but you know what they gave to prisoners? They did a double-blind crossover study on prisoners, and they gave them omega-3s, and then switched over and gave them placebo. And their offending rate in prison decreased in the group that they were taking omega-3s. So it seems to have a phenomenal impact everywhere.
tomorrow I hope that investigating colon cancer may come up with some sort of weird hypothesis that
That's the issue of statistics, isn't it? So that's the comment made by the urologist. Driving a Cadillac can give you prostatic cancer. You could make an association there. There's so many variables involved. They need to be evaluated properly. And yet, to do a randomized control study is not going to be easy for something like this. But I suppose it'll happen in time.
When back to the anti-inflammatory effects of omega-3, will it have a role in children who have
Blepharitis.
blepharopericarditis in children?
Yeah, I mean, we do actually. We have patients who've got this problem. We give them a capsule of omega. We get the mothers to squeeze it out into the orange juice. Yeah, I think it's.
The doses for kids would be the dose for kids,
Yeah.
for children, would be the same.
Well, it's by body weight. So instead of taking, and the recommendation is they take 4 capsules a day for adults. Well, we just give them 1 capsule, squeeze 1 capsule into oranges, depending on their size. Yes, Paul. Sorry.
Oh, sure. I'm not sure you mentioned that you use doxycycline in the drugs.
No, I did. Right? I use them, but not that frequently. They do help, but they're not treating the cause.
No.
So you can put them on a course of doxycycline for 3 months, and hopefully they won't have problems with their stomach and so on. And you actually don't need to give them a big dose either. You can give them you can give them 25 milligrams of doxycycline. It's probably good enough. And we learned that from the maxillofacial surgeons who use this thing for periodontitis. They use 25 milligrams a day. Patients don't like. I mean, I've had patients that have great success with it, and you can't use it in isolation. But I figure if I can change their mibome in 3 months, Why bother with the doxycycline? So if in the past we used doxycycline a lot, but if you have a patient with severe blepharitis, I'll use azithromycin. I'll put them on 500 milligrams for a week, give them a week's break, and then put them on for another week. And it's amazing the dramatic change that takes place in their lids. But they've got, I've got a reason to put them on it. But both infective and inflammatory. And yes, some of that stuff gets deposited in the keratin and transforms some of the changes that look chronic. But the fundamental problem is still omega deficiency, omega-3 deficiency. So you address that, and things start to get better. Yeah.
Sorry, azithromycin had some related with the side effect of cardiac effect and some deaths.
So I don't.
There is a side effect of the azithromycin now,
Yes.
which is on the cardiac and some death.
Mhm.
So, I
Yeah.
don't know about that. I
That-
don't know about using azithromycin for using doxycycline.
How many times have I used azithromycin the last year? Twice. I don't use that often. I get a lot of dry eye patients.
Just for the formation, but
Yeah.
we know that there's a cardiac.
Marcella, you want to say something?
I guess, I mentioned computers in this. I'm convinced that this new era of using computers for everything, including reading, is partially responsible for the epidemic of dry eye that is happening.
They don't blink.
When we were studying, nobody talked about dry eye. There were no artificial tears about it. That was now, that's the options. But I'm convinced that the use of computers has a lot to do with it.
Yeah, it probably tips they're sort of equilibrated, but then when they start using these tablet devices, they're staring at the screens and never blinking, they get a problem. Yeah, we just saw the kids with iPads sitting there with iPads and they start complaining about their eyes burning. Well, you can take a look at them, they're glued, they're never blinking. Great, well thank you very much for attending at an early hour, and hope you have some benefit from the story.
It's a paper.
Thank you very much.
Yeah, that's very good.
Good. Very useful. Okay. Did you get it? Hi.
Yes, I do. I'll be getting in touch with you.
Yeah, sorry, Alex.